didn't have, she had some renal dysfunction. Most of it appears to be, maybe some of it I thought was AKI from the infection itself, and maybe she's a little bit dehydrated also. But I would like to define that renal failure a little bit more. On ultrasound, you said it was mildly enlarged, Pradeep.
Yes.
Do you by any chance have a urine analysis or a urine electrolytes on her? Can we say whether this is pre-renal or not?
No, sir. Actually, complete urine analysis was done, sir, but urine electrolytes were not done, sir. Complete urine analysis was showing traces of albumin, sir, and
Okay.
6 to 8 epithelial cells.
So you don't think this is pre-renal? You think it's actual renal failure?
Yes,
you think it's kidney?
Sir, there were also epithelial cells in
Okay.
CUE, complete urine examination. 6 to 8 epithelial cells were there, sir.
Okay.
So intrinsic tubular necrosis and suspect.
Yeah. Well, we see both. We've seen FSGS also in them. So it's not just ATN, but you'll also see FSGS. We biopsied a couple of patients just to see what this renal failure was from. And surprisingly, FSGS was there very early. So we couldn't explain how quickly this develops in patients with this. But I see that this early signs that this is multi-inflammatory syndrome. And I take that point about giving antibiotics just like that. I would be cautious. I agree. Not only you will get secondary infections, but you're also creating bacterial resistance all over the country because everybody is getting antibiotics. I think those are good points.
Do you consider in this case, just like in most of the pediatric patients or the younger adults we are treating with IV immunoglobulins along with the steroids, would have been changed the outcome a little bit better outcome, early recovery?
Dr. Anne, use your microphone, please.
No.
So when you're treating multi-inflammatory syndrome, what treatment is the best? People have used high-dose steroids, as you said in the first instance. We have used steroids with IV immunoglobulin. There's another group. First of all of us have seen only about 5 to 6 cases, well-defined. I think we've seen about 10. We've seen 3 kids and about 7 to 8 adults. In the adults, we give immunoglobulin with steroids. My pediatric colleagues are against giving immunoglobulin. They say steroids is enough in kids, that they respond quite well. There are people who used, as in this patient, remdesivir with steroids for multi-inflammatory syndrome. The one thing that people don't want to use, based on anecdotal experience, is tocilizumab. I think 2 or 3 patients who got it actually died. So that's one thing I wouldn't use, and I don't know why they died. But I think high-dose steroids is fine. I think the pediatricians are reluctant to use IVIG that much. In adults, we use it because we treat a lot of TTPs and whatnot, and Guillain-Barré. So we're quite comfortable using immunoglobulin, but I think pediatricians are less reluctant to use them. But I don't think there's one is better than others. I think you could start steroids, they don't respond, I would give IVIG. That's how I would go about it. But even before that, you want to define this to be multi-inflammatory syndrome. I'm not ready to say that yet unless you show me an echo. The troponin was normal, it was not elevated. So they're not all the features that I want to look at into calling it such. So I think I'm comfortable with the treatment they gave right now.
Yeah, Sridhar, as you rightly mentioned, multi-system inflammatory syndrome child or children and multi-system multi-inflammatory syndrome adult. For the PG's knowledge sake, I'm repeating the criteria. For a MIS-A, the patient should be more than 21 years old, and the diagnosis would be made within 12 weeks, either by an RT-PCR or a rapid assay, and cardiac, nephro, and other system injury or involvement must be there. The LFTs, ALT, AST should be raised. And conspicuously, they say the respiratory system involvement is absent as far as MIS A is concerned, adult. As you said, she is 18, below 21. That's why it comes partially under MIS C.
Yeah.
Okay.
It's funny that when this syndrome was developed, CDC, when they first wrote it, they forgot the age group 18 to 21. The syndrome went to up till 18 one group and about 21 one group, and they didn't know where to put the 18 and 21. So now they put them into the pediatric group, but it looks like that's a gray zone, what happens to 18 and 21 still.
This might become important when somebody is collecting large volumes of data below 18, 18 to 21 adults, etc. But as Pradeep was presenting the case, I was stuck with 18. Physiologically, 18 is the same as 21. For the sake of discussion about management, I was wondering if there are no other questions from the elders, as I call them. There is one participant right now who raised a topic regarding the 18 years of age. He himself, a doctor in Rochester, New York, one of our alumni, was ill and just got discharged. So I put him on hold. I'm waiting to see whether Dr. Chilimuri, Prem Kumar, or Narsingh Rao have additional comments before I ask Dr. Srinivas to speak. Any other comments on this particular case management? Please.
So in this particular management, I would like to ask Dr. Chilimuri, routinely we are adding doxycycline, ivermectin, vitamin C, zinc in all cases. I think it's right time to drop these medicines and just either giving remdesivir or not, either giving convalescent plasma early or not, plus steroids.
Fully agree. I don't see there's any, I don't see any value in giving doxycycline, no data, and it probably creates bacterial resistance. Now, the role of ivermectin, we don't use it at all in the United States. So there's only one particular reason why you want to use ivermectin. The British use it, but not in the first week. So the theory behind this is a lot of people have parasitic infections and you're about to embark on a very high dose of steroids on them. So if, let's say, assume they have strongyloidosis and you're giving high doses of steroids in them, you can get a hyperinfection syndrome from strongyloidosis. So that's the concern. So in that instance, is it okay to give ivermectin? Probably it is. But if you're giving it to treat COVID, I think that's absolutely no basis for it. This whole ivermectin came based on a study, in vitro study, where it showed antiviral activity, but the doses that you need to get that antiviral activity is so high that the dose at 12 milligrams that we're giving is absolutely nowhere near. You need to give like 400 milligrams or so to get that virucidal levels. So that is, and that's impossible to achieve. So I wouldn't use ivermectin as an anti-COVID treatment at all. Likewise, zinc, I don't see any value. There's some who say if you have diarrheal illness that 25 milligrams of zinc may be useful. I've not seen it. No data supporting it. And vitamin C likewise. No data showing any value. I agree. I think vitamin D definitely has a role. Again, there's no real evidence for it. There's only indirect evidence that when people did poorly and you knew your vitamin D levels, if they were low, there generally was a predictor of bad outcome. If it's normal, they did better. But these are retrospective cohort analysis. So somebody needs to prospectively give and see whether it makes a difference. I would give it. There's no harm in giving it. This hypocalcemia that she got is quite significant. So it is similar to a tumor lysis syndrome that reported with Ebola virus. Hypocalcemia is extensively reported in COVID too.
Yes.
And the mechanism is thought to be maybe a virological cytophagolysis rather than a tumor lysis. This 18-year-old unfortunately had that. And the mechanism is unclear even now. There are people who did parathyroid hormone levels and saw alterations in that. If you look at her, she has multiple endocrine involvement. Look at her kidney, pancreas. She's 18, not known to be diabetic. Pradeep, you have to tell us if there's a family history of diabetes, but I'm assuming there is none.
No, sir. No, sir. No
Why
family
would,
history.
so she suddenly gets islet cell dysfunction with COVID infection, which is interesting because there's enormous amount of ACE inhibitor, ACE receptors in the pancreas.
Yes.
It's quite likely it got inflamed. We do lipase levels as part of a research study, and 30% of them will have elevated lipase levels, although pancreatitis is uncommon. But it's suggesting that this virus viciously attacks the islet cells as it would attack other endocrine cells. So I think it could be cytokine mediated, or it could be virus itself causing cytopathic effects. This young woman has lots of problems, unfortunately. None of
Previous
yeah.
literature was showing 50% prevalence of acute hyperglycemia in COVID patients, sir. And only 7% of them were diabetics, sir, non-diabetics.
Yeah,
All rest of them developed new onset hyperglycemia.
Dr. Chilumuri, we have seen quite often patients that have really hyperglycemia poorly controlled. When we started treating with the steroids, surprisingly, their hyperglycemia is controlled easily with lesser dose of insulin. And it's very indicative of more of a inflammatory markers that are inflammatory cytokines that are probably part of it is probably responsible for the dysregulation of this most of the endocrine system.
Yeah.
And also, sorry, and also to just add a comment that you made that IL-6. This is a very interesting cytokine. In fact, if you look into the IL-6 membrane bound is anti-inflammatory effect, and IL-6 free form is more of a pro-inflammatory effect. So that delicate balance is very important in how to control the body controlling the inflammatory response. So that's one of the reasons we are seeing quite often with anti-IL-6 treatment developing into sepsis, developing into other complications. So we really stopped using the anti-IL-6 antibodies.
Yeah.
And finally, as a pulmonologist, I am interested in the oxygen therapy. Pradeep,
Sir.
actually, in this pandemic, I have observed as the patient is brought into the ICU. Earlier, there were guidelines in COPD, don't give more than 2 to 3 liters or don't cross 35%. Otherwise, COPD patients might go into CO2 narcosis due to respiratory central depression and all those things. But here, this pandemic, I have observed, once the patient is brought into the ICU in a panic response, doctors used to keep the patient on 6, 10, 20 liters NRBM like that, and totally we forget about that caveat. And here, beginning 6 liters you have started, whether you have transitioned to high flow devices like Venturi or HFNO. I didn't see you are using anywhere HFNO.
Yes, sir. Sir, she was maintaining on mask only, sir.
Okay, fine. See, after HFNO only NIV. You have gone frequently to NIV, and the oxygenation seemed to be waxing and waning. One day improving, the next day you are putting the patient on mask with oxygen, and again that saturation is dropping. See, when the patient is requiring 70% oxygen with a PEEP of 8, the next day you are keeping the patient on a mask with 6 liters or 8 liters. I don't think it's correct. And, in the COVID, though the lungs are normally compliant in certain phenotypes, there is a very increased respiratory drive. And, the inspiratory flow rate requirements are very high. I don't know why you have not used HFNO in this case.
I'll keep in mind, sir.
Okay.
Did you
And
prone
after
the patient at all? Did you prone the patient, Pradeep, or you didn't try proning on?
Sir, as I told previously, a patient was uncooperative, sir.
Okay.
And,
Okay.
yes.
Prem Kumar garu,
Sir.
did you notice in patients that when you are using the pressure breathing and increased pressures, you are seeing quite frequently the pneumomediastinum, pneumopericardium. So we're trying to avoid the high pressures in these patients because of the less compliance in the lung tissue. We're seeing more of these pneumomediastinum, etc. Can you comment on that?
Yeah,
Probably you have
actually,
more experience on that.
high pressure is different from high flow oxygen. HFNO, where for every 10 liters of flow, it will develop 1 centimeter H2O of PEEP. For example, you kept 60 liters, the highest flow. Even then, the PEEP develops in that system is only 6 centimeters. So HFNO doesn't produce much larger pressures. Whereas, just like this patient, when it is kept on an NIV with a mask, probably there may be a possibility of we keeping high pressures or patient is non-compliant. Or if you do an invasive, intubation and invasive closed system where the cuff is distended and that becomes a closed pressure system in intubation, then probably high plateau pressures and even more, the high driving pressures. Driving pressure means the difference between plateau and PEEP. More than 14 is causing this barotrauma. But anyway, you have rightly commented. And one of my colleague from Srikakulam RIMS, my junior, actually my student, he said he has seen and he has sent me the films of 2 pneumothoraces and 1 pneumomediastinum. And even in WIMS, we have seen 2 pneumothoraces, even with HFN. But only thing is, I feel whatever little or less amount of oxygen that is required to maintain a saturation of 90% or above. See, ARDS network says the goal is 88% to 92% saturation, or 55 millimeters of mercury of PO. Why not the same goal here? Why should we aim at 96? So the minimum amount of oxygen that is required to maintain above 90 would be sufficient. But unfortunately here, as a panic reaction, just 10, 15, 20 liters like that we are giving. And HFNO also probably people need training where to start, like 30 liters, and gradually we have to increase 40, 50, 60. And FiO2 also you start at 50 and gradually increase, and how to wean off the HFNO, like every 2 hours 5 liters flow and 5 liters 5% FiO2. So if the postgraduates who are directly on the scene, if they are trained well with the HFNO settings and how to escalate, how to wean off from the HFNO, I think these barotrauma kind of things can be prevented.
Well, how are we doing for time, Dr. Sudhakar?
Okay, we can go for another 10 minutes, 10 to 15 minutes.
You're muted, sir, Dr. Kairab.
The postgraduates or others who have logged in here, so that Pradeep or others can answer.
So there are 2 sets of postgraduates now, those in pulmonary medicine and those in internal medicine. Is that right?
Yes.
Yes, sir.
And this case was handled in internal medicine. Are there any pulmonary fellows online right now? You can unmute yourself.
Yeah, they've done.
Okay.
Priyanka has unmuted herself, and she can go ahead and ask the question if she wants.
Okay. If Priyanka is there, she probably doesn't have a question. I was only curious about how in a disease like this, relatively new, if in one part of the hospital there is an internal medicine PG with a case where he's increasing and decreasing oxygen flow or thinking about what drug to use. And building away is a pulmonary division head. Do those postgraduates contribute, or is there a pulmonary consult available? I'm asking a naive question.
Yes, sir. We also have a pulmonary medicine PG, sir.
Did he come by?
Yes, sir.
Okay.
Both of us used to see the case.
All right.
Along with the anesthetists, sir, critical care people, pulmonologists, physicians, and anesthetists also will handle the critical cases, sir, in ICUs.
Okay, I have a question to Prem Kumar.
Sir.
Prem, what do the state guidelines tell us with regard to the ivermectin and zinc? We were discussing about the ivermectin and the zinc, number one. Number two, are we really following all the protocols that have been given by the state headquarters? Now that you are in that forum, you can enlighten on that as to how to make people understand what is needed, how to make people follow these guidelines or the protocols that were enunciated in the state at the state level, and how to make changes in that if they are not logical.
Yes, sir. Unfortunately, the state guidelines still includes hydroxychloroquine in mild and moderate cases. Still, it is continued. I think we have to take it to the notice of the policymakers that undoubtedly the Placid trial or the recovery trial even and the Brazilian trial or an ORCID trial, they just refused to use hydroxychloroquine, but still the Ministry of Health and Family Welfare, Government of India guidelines continue to use hydroxychloroquine. And regarding your question, zinc is advised, whereas, ivermectin is not advised by the guidelines.
No,
I'm more concerned about the hydroxychloroquine. Still, it is there in the guidelines for mild and moderate cases.
now
But sir, at the ground level, everyone has done away with hydroxychloroquine, sir, with vigorous promoting and propaganda. People have, healthcare professionals have done away with HCQS, sir.
That's
So
what the problem is. Now I am in the state committee. The government or the IAS officers, they insist on us to stick to the guideline. So, but in the guideline, it is there, hydroxychloroquine. So I think I have to take it to the notice of the policymakers about this and to remove the hydroxychloroquine from the regimen. Otherwise, it's dangerous, it's harmful. So that is one point which we have to highlight. And in the guideline, in the moderate disease, the steroid is advised dexamethasone or methylprednisolone for 2 to 3 days. In severe case, it is advised 5 to 7 days. I think that is a little less of a duration, and probably it might require even up to 10 days. Just like, patient on mechanical ventilation or ECMO, they are allowed to use remdesivir for 10 days. Like that, at least 10 days of steroid is required, but the guideline says moderate disease 3 to 5 days, 2 to 3 days. Severe disease 5 to 7 days. Needs to change.
Too short, sir.
Yeah, that needs to change. And finally, if Dr. Sridhar is there, I have one question regarding the anticoagulants. See, there's a lot of debate about low dose or intermediate dose or high dose, anticoagulant. That is, 0.5 mg kg OD or intermediate 0.5 mg per kg BD, or high dose, that is 1 mg per kg. Say 60 kg means 60 mg BD. So 3 kinds of doses. And at the same time, there are, around 11 to 14% incidence of bleeding is also there. So how to go about it in severe cases?
Yeah, the first thing is you want to define why you want to anticoagulate. Let's take her as the case. She's an 18-year-old. Other than that, she has a high D-dimer now. I don't see any evidence of thromboembolic disease in her. So I would have done an echo, Pradeep, at some point. I really want to see what's happening with her left ventricle. It was enlarged. Is it still like that? What is this bradycardia that she developed? Is it a conduction defect or is it a cardiac defect? Does she actually have a thrombus sitting somewhere? So I'd like to define, well, does she have a thromboembolic disease, or all we're seeing is a high D dimer? Let's assume your treatment of remdesivir and dexa reduced the D dimer and it's back to normal. Then once she's discharged, there's no real indication to give her anticoagulants at all. But let's assume her D dimer still remains high, or in your workup, you found a thromboembolic phenomenon of some kind. You can define it, or you identify a thrombus. Then the issue of anticoagulation and how much dose you want to give. Currently, there is no data showing that intermediate dose versus higher dose makes any difference in the overall outcome. I think the key thing is to decrease the inflammation one way or the other. Anticoagulants per se there's only one major study from Sinai which showed that anticoagulants decrease mortality. No one else has shown it. We give it, but no one has shown that it actually saves lives. We're doing it more or less to treat ourselves more than patients, it looks like. So in her case, I don't see any thromboembolic phenomena. Maybe Pradeep will work her up a little bit more and define it. If there's none, I would just give her in the hospital, and after that, stop it. I wouldn't give her anything after that. But she's still not out of the woods. At some point, I would repeat her D dimer to see if it's still elevated or has come back to normal. I hope it's back to normal, then I wouldn't give her any anticoagulants at all. I need to know, is there a risk or is there a defined thrombus before giving long-term anticoagulants?
And last and final, Dr. Sridhar, are you there?
Yeah, I'm here.
Recently, I was auditing, I'm making a death audit in a medical college hospital's case in the presence of the IAS officer who is in charge of all these things. So they said the patient is on, NIV and all those things. That's also a very young 21-year-old lady. And finally, they said patient died. So the question was, we were asking why you didn't intubate and all those things. So they said it's a sudden death. It's a sudden death. So then the question came, the supervising IAS officer asked how to prevent this sudden death. Just because you didn't want to intubate, that you are saying it is a sudden death, or it's really a sudden death. If it's really a true sudden death, how to prevent a sudden death in youngsters? Is there any way to prevent them? Is it any way to pick up early? Do you think that doing the inflammatory markers, TROPI and everything 2 to 3 days, every 48 to 78 hours, will it would have saved that girl?
I wouldn't know, but I would definitely do an echo on her because the heart is crying at you. It's telling you something is off. Why would a 18-year-old have severe bradycardia? You have to explain that. So is she at risk now for sudden cardiac death? Yeah, I mean, you have a heart that's suddenly developed left axis deviation. You have a heart which, at least on CAT scan, looks marginally enlarged. A good echo is absolutely important for us. We have to know what's happening with our heart. Yes, I think, can I prevent it? That's the difficult question. No one has so far. When it happens, it happens. But here the D dimer is high, so I think anti-inflammatory drugs like dexamethasone being the most important one that in clinical trials has shown to save lives, that would probably decrease it. In her case, I'm worried that she has a thrombus or thromboembolic disease in her heart. That's my worry. I wouldn't be surprised even if a coronary angiogram will be abnormal in her. I'm not saying do it. I'm just saying I wouldn't be surprised we've seen it. Because this inflammation involves many endothelial cells. So there may be severe activation of her endothelial system, so she could clot. There's a recent paper showing that in younger people, and in her case, her neutrophil count is high. There is something called the neutrophil extracellular traps, which are actually a normal physiological phenomena that's gone wrong in COVID patients, and they develop microthrombi, particularly in the coronaries. She has some features of that bradycardia and that tachycardia in the beginning. So if her echo is abnormal, I think she's at risk for sudden cardiac death. What can we do? I would continue anti-inflammatory drugs, for instance, steroids, and I probably will give her anticoagulants at that point. So Pradeep, I think an echo is important to get on her.
Yes, sir. I'll do it.
Sir, I have also seen quite a few bradycardia cases, sir, as opposed to tachycardia, which you normally expect in COVID. I've also seen, but I didn't work up detailedly, sir. But all went through safely, sir. But I was also surprised. Sir, one more question can...
Even remdesivir or methylprednisolone can also...
No, sir, not on remdesivir, sir. Remdesivir also we expect bradycardia, but without remdesivir, I've seen quite a few cases.
Even methylprednisolone can also cause bradycardia.
Yes. Sir, I have one question can be allowed, sir, to Sridhar Chelumuri, sir.
Yeah.
Sir, this is not regarding this case, sir. In your first presentation on this forum, you said pregnant women are at an increased risk for COVID-19, sir. And surprisingly, psychiatric patients are at not at an enhanced risk.
Yes.
You remember, no, sir, in your presentation, your study, you said. In several subsequent lectures at different forums on the pregnant and COVID, I have contradicted based on your points, sir. But none have come out. They said it is the normal risk, normal prevalence, and normal incidence in COVID. Regarding COVID-19 in pregnant, they are not at enhanced risk. The other speakers were saying, sir. I'm just bringing to your notice, sir.
So
your hospital observation.
No. I hear you, but I think the CDC now made it official. Pregnancy is an increased chance of infection, and pregnancy has worse outcomes. That's well known in the United States now.
Yes,
that
sir.
was our initial observation. Now the CDC makes pregnancy a risk for infection.
Yes, sir.
And also makes it a worse outcome. Interestingly, remdesivir works well in pregnancy-related COVID,
yes,
better than non-pregnant patients. Now, with regard to psychiatry, if you notice, there is a prospective randomized trial that was done where an antidepressant, it's an SSRI, that was used as a treatment for mild to moderate COVID. Actually, one of the few randomized placebo-controlled trials which showed that it actually is beneficial. So after DEXA, this is one of the first few drugs which shown. So a larger scale trial is about to start by the NIH because they were very impressed with the prospective trial. So it may be an observation we made. I think in time we'll see more about it. I still see fewer COVID patients in our psychiatry unit even today. Even in the second surge, we don't see much COVID.
Thank you, sir, for this new observation on SSRIs in psychiatric patients. Thank you, sir.
I would like
Congratulations, Dr. Pradeep.
Okay. Thank you, I would like to make an observation for both of you. Pregnancy is obvious, psychiatry is not. Yeah. There are many psychiatry patients that are undiagnosed, so it will be very difficult to study relationship of COVID with psychiatric disease, which psychiatric disease, what degree, treatment, etc. So I think it's relevant to discuss pregnancy because it has implications for immune function, but not so much as psychiatry, I think.
But sodium valproic acid is an immunoregulatory drug. It definitely has been tried in autoimmune diseases in the past. So it's not a surprise that sodium valproic acid will do something to your immune system. In COVID appears to be favorable.
Then you could easily test that in the epileptic who's receiving sodium valproate. I'm just suggesting this kind of observation that will come out sometimes might turn out to be premature if they have not been studied in a population. Such studies are a bit lacking. Dr. Sudhakar.
Yeah.
Although the format of this is Pradeep's case, because of the young age of the patient, because we have one participant right now who's actually one of our alumni who had been himself ill in Rochester, New York, and has just come home. And he was going to make a comment regarding his illness. I was simultaneously texting him regarding his initial presentation, incubation period, most likely contact, where he got it from, presence or absence of anosmia, initial symptoms, to benefit from the presentation features that were not very easy in this case. So if I have only another 5 or 7 minutes, I'd like to invite Dr. Srinivas Jonnala. Is that okay, Sudhakar?
Yeah, please ask him to go ahead.
Srinivas, please proceed. Srinivas, I have unmuted you. You can unmute yourself.
Journal. Are you there?
Yeah, go ahead, Srinivas. Srinivas, you have to unmute yourself.
Okay, sorry.
Okay. Go ahead, proceed.
Can you hear me, sir?
Yes, please proceed.
Okay.
Yeah, we can hear
I
you.
was saying I have a practice here in Rochester, New York for almost 20 years. I only joined this because Prem Kumar was 1 year senior to me and I wanted to listen in on him. And of course, Dr. Kairam, I had the pleasure of just meeting recently. So through a mutual classmate. But just a very 5-minute summary, I can give you what I went through and survived COVID actually. Only recently, 2 weeks ago. So March 14th, we shut our office down because of the number of cases. And we only saw people in the office with face shield and mask till July. Then July, as things were slightly improving here and the wave was getting better, we started seeing 50% patients in the office. And that's how we were managing. And anyone who was mildly ill, we sent to urgent care centers and drive-through testing centers. Well, late November, one of my patients, which I know exactly now in retrospect, hindsight, was ill. He called the office with mild flu-like symptoms, and he asked to be seen. And our secretary said, well, we're not doing testing in the office, so please go and get it tested at urgent care. He declined. So, you know, you can't refuse patient care. So they gave an appointment. I saw him end of November. And he was not hypoxic. He was afebrile. In fact, he had an outpatient COVID test a month prior because he had a pre-elective hand surgery. So he looked fine. He just had mild wheezing in the left lower base. I gave him some albuterol and I thought it was like a viral bronchitis, and I told him he needs to get tested, and he said he would. So that was him. So 2 days later, he showed up on my inpatient list that he was admitted at another hospital with COVID, hypoxia, respiratory failure, and pneumonia. So then I got nervous. I continued to work, but I had really no symptoms. Then my initial symptoms were just a dull headache and diffuse fatigue and myalgias. So on December 8th, I went and, at my wife's insistence, got tested. I had a nasopharyngeal swab. It was at an urgent care center, and the average turnaround time now is about 3 days here. And then that was on a Saturday. So I just stayed home on Sunday. Monday, I was fine. I actually went to work, believe it or not. Wore all the precautions. Tuesday, I was fine. I went to work. I saw like 16 patients. And then early Wednesday morning, my test came back results online that it was positive. So I called my office manager, canceled all my patients, and just kind of stayed at home under home quarantine because I was feeling fine. My pulse ox was in the mid 90s. Really no symptoms. I just rested at home on the where are we, on the 9th, 10th, and 11th, sir. Then in the meanwhile, my mom lives with me, my father-in-law lives with me, my wife. So they all started wearing masks. We all stayed in our own houses and room, did our own thing. So I was fine on 9, 10, 11. On a Saturday morning, I couldn't breathe. I couldn't get out of the couch. I went to the bathroom, and then my O2 sat was 85%. So my wife called the ambulance. I went to Strong Memorial Hospital, University of Rochester Medical Center. They did a chest x-ray, which showed bilateral pulmonary posterior mild opacities. My CRP was 175. My D dimer was 0.9. And that was it. My CBC, Chem 7 were fine. My O2 sat surprisingly was still in the low 90s, but I was so dead tired I couldn't even get out of the stretcher. So they decided to admit me. I was in the hospital from 12/12 to 12/17. I was on 6 milligrams of dexamethasone by mouth daily and remdesivir once a day. That was it. In addition, they gave me insulin, short-acting and long-acting. I also have pre-existing type 2 diabetes. My blood sugars were running in the 300 to 400 range, so they managed that. They also gave me not therapeutic Lovenox, but more prophylactic Lovenox. So I basically lay in bed for them the 12th to the 13th, just staring at the ceiling. They had me do prone positioning for 2 days, which I tried to do, but I was too tired to even turn around. The nurse, I was on a COVID floor with another gentleman who was also, suffering with what I was doing. So, so that was that. Then on the, where am I at now? Okay, on the 15th, I tried to get out of bed, could barely still walk. I tried again the next day, went around the nurse station, which is about 100 feet, had to stop 4 times. It felt like climbing Mount Everest, basically, when you can't breathe. Yes.
Srinivas, can you stop for a second?
I can, sir, I can.
Yeah, it is true that you went through all of this. For the rest of your presentation, see if you could make comments regarding your presentation, your course, Pradeep's case, and if you would have any other comments, because yes, it is a long story, but I want to stay close to and faithful to Pradeep's case, please.
Okay, I'll try my best, because I can only tell you what I experienced, and I'm just telling you as fast as I can. So my O2 sats remained low.
Yeah, the problem with that will be, it will become an anecdote. I would like to see, because you're a practicing doctor, to convert that into a learning experience for Pradeep.
Well, I'm just happy to be alive, sir. I'm sharing my story. Okay, so anyway, fine. I'll just very summarize. So the 17th, I came home on 2 liters home oxygen. I tolerated remdesivir fine, and I'm doing well. Initially, I had to use the oxygen. I'm recovered completely. I'm not even using any oxygen right now. And that's my story. My EKG was normal. Everything else came back fine. I'm just thankful and happy to be alive and back home.
What point in the course
I think the remdesivir did make it.
At what point were you given steroids?
I'm sorry. Why was I given, or was I given?
At what point were you given steroids? Right from the beginning?
Oh, no, they started it on the same day, sir. On Saturday, they gave me 6 milligrams oral. They started it right away.
Okay. Dr. Chilamuri, comment regarding what was done in Rochester, what could have been done in Vizag, and what's the learning point from here?
I think what Rochester and Vizag did the same. This child also, the 18-year-old, got remdesivir and steroids, which is what they would have done in Rochester, and obviously he has done well. So that would be the appropriate treatment to give remdesivir and Dexa. His major improvement is probably from Dexa, and remdesivir helped shorten his length of stay in the hospital. I think what I would watch is what would happen to his diabetes going forward. We found pre-diabetics who developed hypoglycemia during COVID end up becoming diabetics, at least 20 to 30% who were pre-diabetic after recovery ended up having diabetes. So I think after discharge, he should monitor his glucose carefully. There's a chance that he may end up developing diabetes now. So, and at some point, I would repeat his D-dimers just to make sure they're back to normal and stay normal, because you could get post-COVID syndromes, particularly maybe in patients who are at risk for diabetes. So I would just at least 4 weeks in, I would do 1 D-dimer level to see it stays normal. And watch for post-COVID syndromes. Yeah.
What about the multiple antibiotics given in Vizag? I was writing them down as he was giving a list, and also Ivormectin comment.
Antibiotics are used widely even in the United States. Unfortunately, I think one of the speaker alluded to there's some panic. And so there's, you have a severe pneumonia, you have an impending shock often, and you don't want to believe a viral infection alone is doing it, even though it is doing it. So it's not uncommon, even in the United States, to use some form of antibiotics. A broad spectrum antibiotics is given. I think we need to stop that practice. I think in the second, third week, using antibacterials are appropriate because they do get secondary infections, but not so in the first 1 week of infection. I think it's rarely bacterial. So giving any form of antibiotic like azithromycin, doxycycline, which is widely used in the United States too, is of no value. I think soon we should stop that.
Okay. The next
Sir,
question.
can I say something? Sorry,
Yeah.
Go ahead.
go ahead. In my case, actually, the day before on Friday, I called my doctor's office and they started an outpatient respiratory clinic and they said, come in. They did a chest x-ray the day before. It showed bilateral infiltrates. And he did start me on azithromycin empirically. I stopped it the next day when I went to the hospital. They said there's no need for it.
I agree.
Okay.
I agree. It just nauseate you. That's it. It's not going to help you.
Right. It just made
more.
me nauseous. I wasn't too happy.
Okay.
Yeah.
There's one question from the audience. Which steroid is preferred? Methylprednisolone or prednisolone or dexamethasone? Should we consider sugar levels also when considering steroids particularly?
I think there's no data showing one steroid is better than others. It's availability of whatever steroids you have. I think in some countries, dexamethasone is not easily available. So they switch to methylprednisolone. That is fine. I think if there's one steroid I won't use, that would be hydrocortisone. That's not been so useful in practice. So methylprednisolone or dexamethasone are fine. Prednisone is also fine. The sugar wouldn't bother me. I think the only life-saving drug in COVID is steroids. I would manage the sugar with the insulin if I have to, but I would not stop somebody from getting steroids just because of hypoglycemia. That is a life-saving drug, and I would not hold it in somebody who is moderately to severely ill.
Well, Dr.
Can I say something? Sorry.
Go ahead.
I was just wanted to say that both my wife and my mother tested positive subsequently, but they're doing well. They just stayed at home and they had mild symptoms and they recovered, basically. So they're good.
Well, on behalf of the participants in this meeting, I am happy to hear of a good outcome both for you and for them, but please stay safe and protect the children. As we notice, we have been discussing an 18-year-old. I see you have a teenager in the house.
I do.
Okay. Dr. Sudhakar.
Can I just say something? Can I just say something with a sense of humor, if you don't mind?
Yeah. It depends on how humorous it is. Go ahead.
I think you'll find it humorous. Well, those 5 days I could barely get out of bed. I had to use a urinal, and the nurses were gods. They basically emptied the urinal for me. And it made me think of a famous scene in a movie called Castaway with Tom Hanks, with his volleyball, when he's talking to it for 2 days because he was stranded on an island. So the urinal to me felt like my Wilson. So I'll leave it at that.
Yeah, we got it. Dr. Sudhakar, I think for the purpose for which you wanted this, it might have gone well. It has to do with muting microphones, etc. So I think next time we'll be more prepared. But on behalf of Dr. Sudhakar, before he comes on, I want to thank Dr. Chilimuri for coming on and staying on, and for the senior staff, and for Dr. Prem Kumar to conduct it in such a way that the PGs will take away lessons for the next case. Dr. Sudhakar, you're on.
Yeah. Thank you, Dr. Ram, and thank you, Dr. Chilimuri. Thank you, sir. Sudhakar, sir.
Yeah.
Thank you.
Thank you all, Prem, Dr. Kairam, and Dr. Chilimuri, for making it so interesting. I'm sure that this is the way I think it should go. And from next week also, we'll have another similar session. On 17th, a week later, we'll have a guest lecture again by Dr. Suresh Anne. So after that, I'll be requesting Dr. Sridhar Chilumuri or Dr. Ram Kairam to take another topic. So we will have this format every 2 or 3 weeks, once in every 2 or 3 weeks. I think today's presentation has been good in the sense that we have learned a lot of lessons, particularly to identify the source of infection and also the importance of evaluating properly, particularly the cardiac evaluation through echocardiogram. That is a very, very important point that has been brought out. Apart from what we have discussed with regards to the management like ivermectin and other points. So these are the learning points that we had today. And with I thank everyone who has participated in this session. And I hope this would be continued in the next week also. Till then, bye-bye.
One quick comment. We had 99 people today. I think this particular account has a limit of 100. So those who are on might be asked by other people who had difficulty coming on to say that by the next meeting, I will increase the number to 250. So we will never run into it again, because it is not surprising if somebody said, oh, I tried to get on, but I could not get on. So let it be known that by next week, we would have an audience of 250. Okay, so we are saying goodbyes.
Yeah, bye-bye. Goodbye.
Bye.
Thank you, Dr. Chilumuri. Bye-bye.